And we are live.
Good evening. My name is Coretta Bozeman, and I am a member of Gamma Omega chapter of Alpha Kappa Alpha Sorority Incorporated. I serve as one of the moderators for this evening. I currently serve as the general chairman of Gamma Omega's Centennial Celebration, a legacy of excellence in service. We are excited to partner with the men of Phi Beta Sigma, Kappa Sigma chapter to sponsor this pink and blue health empowerment event as part of our centennial celebration. One of Alpha Kappa Alpha Sorority's international program focuses on women's health care and wellness with an emphasis on breast care awareness and prevention. And October is Breast Cancer Awareness Month. So we will bring in the month providing information and a call to action for this critical health issue for women.
Good evening, everybody. My name is Robert T. Jordan Jr. I'm a member of Phi Beta Sigma Fraternity Incorporated. Welcome you and thanking you for joining us this evening for the Pink and Blue Empowerment. I'm a member of Phi Beta Sigma Fraternity Incorporated, and I'm also the state director of Missouri and the immediate past president of our chapter here in St. Louis Kappa Sigma chapter. Okay, one of the programs of Phi Beta Sigma, as we have 3 programs, is social action, which falls in line with Sigma wellness. One of the most important things that we focus on is what affects our community, and especially people that look like us, our culture. So it's important that we got this event going to be informative, and we want to inform people. So prostate cancer is something that affects African-American men at a high level, and you'll have an opportunity to talk with some doctors, ask some questions, talk with some individuals that have experienced this dreadful disease and overcome this disease. So as we sit back and we go forward, please take notes, ask any questions you can put in Facebook, and they will be answered. Thank you for joining us this evening, and thank the ladies for Alpha Kappa Alpha Sorority Incorporated for allowing us to partner with them in doing this event.
Ms. Bozeman, unmute yourself.
Coretta,
Ms.
we cannot hear
Bozeman.
you.
She can't hear us either. Good evening. My name is Kimberly Beck, and I am the president of Alpha Kappa Alpha Sorority Incorporated Gamma Omega chapter, the 3rd oldest graduate chapter in our illustrious sisterhood. Gamma Omega chapter is proud to be co-sponsoring this event with the men of Phi Beta Sigma. Alpha Kappa Alpha is the oldest Black Greek letter organization for African-American women, and we were founded on the campus of Howard University, and from that time, it has been our mission to alleviate problems for girls and women. And breast cancer has been a significant issue in the St. Louis metropolitan area, particularly as we look at statistics in North County, where it is heavily populated with African Americans. We have found that breast cancer has been identified in its late stages and causing devastation. Alpha Kappa Alpha is committed to being a part of the solution. Under the leadership of our international president, Dr. Glenda Baskin Glover, she has directed our focus towards women's health, and we have been doing great things under the leadership of Sonia Bowen, our Central Regional Director, who has armed and equipped us with information to provide to the community so that we can help women take care of themselves and contribute to the community. We thank you so much for joining us here tonight. And as any good woman, we always look out for those in our family, and we wanted to partner with our Greek family, the men of Phi Beta Sigma, to take care of our fathers, husbands, sons, brothers, nephews, and helping them to address prostate cancer. So we thank you for joining us tonight, and we hope that you will find this information informative. Again, on behalf of the 391 members of Gamma Omega Chapter, we welcome you to this event tonight.
All right, good evening. And I bring you greetings from our International President, the Honorable Brother Michael E. Crystal, of Phi Beta Sigma Fraternity Incorporated. Good evening, my name is Dr. Mark A. Hewitt. I'm the president of Kappa Sigma Alumni Chapter of Phi Beta Sigma Fraternity Incorporated here in the great city of St. Louis, Missouri. Tonight, our goal is to provide you with information and resources that you can use immediately for yourself or a loved one. For 106 years and counting, Phi Beta Sigma has been deeply rooted in our motto, culture for service and service for humanity. We have an obligation to our community through our national programs. One in particular, Brother Robert Jordan spoke of, is social action and Sigma wellness. This evening, we will focus on Sigma wellness. Sigma Wellness is our men's health initiative designed to educate and inform our membership and the community about key health issues facing men of color. We're here engaging our communities through dialogue about overall quality of life and solutions to improve our well-being as men. We hope that you enjoy our discussion this evening. Thank you again for joining us. For more information about the St. Louis Sigmas, please feel free to visit our website at stlouissigmas.com. That's stlouissigmas.com. And thank you again for joining us.
So this evening's program is divided into 5 different segments. And the committee members and participants this evening include, and you've heard from our chapter presidents, Mr. Mark Hewitt and Mrs. Kimberly Beck. You will hear from our vice presidents, Mrs. Lanita Blackman and Mr. Mark Cruz, the Gamma Omega Women's Health Care and Wellness Chairman, Mrs. Melanie Davis, and the Women's Healthcare and Wellness Co-Chairman, Constance Carter and Adrian Gaines, as well as our doctors who joined us for today, Dr. Hari, Dr. Glover Collins, and Dr. Bettina Drake. Thank you.
Okay, as we move into segment 1, we're going to ask Dr. Hari and Dr. Catherine Glover Collins. When you speak, take time, and Dr. Hari, you hit first. Take 7 minutes. It's an overview, just to give some insight into these dreadful diseases. And so, Dr. Hari, I would ask, just give a little insight about yourself as well as you proceed, if you can do that. Thank you.
Thank you, sir. Thank you so much for inviting me, and thank you so much for giving me the opportunity to talk to our community. I am a physician who is originally graduated from India, and after I graduated, pretty much in the same year, I went to the Caribbean, and I worked for 10 years in the Caribbean before coming to the United States. And the topic is very relevant to my experience in the past in the Caribbean. And also, as I go into a little bit more detail later, Caribbean African patients are a relatively higher risk than general average population. And as a matter of fact, that's one of the risk factors. So prostate cancer is a very dreadful disease. And so just to give you a brief overview, so first of all, who are the ones who are at high risk, and what are the things that puts you at a higher risk of having prostate cancer? So generally speaking, males who are older would have a higher risk of prostate cancer. So less than 40 years, it's very less likely you will have the risk of prostate cancer. And just to put in the context of every decade, so the risk of prostate cancer, especially the occult cancer, is around 9% in the age between 31 to 40 years, and then 41 to 50, it's about 3 to 43%. But just to highlight the increasing occurrence in age 60 to 70, it is 14% and above, and then 70 and above, 70 to 80, that decade, you'll have 31%, and 81 to 90, it's almost 40% to 73%. That is, as you grow older, it puts you at higher risk of having prostate cancer. And as far as ethnicity, it is much more common in Black men. And also the genetic studies that have done showed that especially Black men who has any ancestry from Caribbean also has a much higher risk. Just to take a very slight deviation, when I was working in the Caribbean, Dr. Lester Goods was one of the urologists there. He did some sort of a comparative studies where he presented to us internally, where he noticed that there is a much higher incidence of cancer in the Jamaican Black men than Trinidad and Tobago Black men. And I actually worked in Trinidad and Tobago. And that's where it became later on much more evident that the impact on the diet and then the vegetable diet, and especially the tomatoes and the lycopenes and active ingredients made a big difference. So if you're older, the older you get, the higher it puts you at risk of prostate cancer. Having the ethnicity is also going to put you at a high risk. And if you have a first-degree relative, these are where the genetic factors come into play. So if you have a first-degree relative, that immediately puts you at a higher risk of prostate cancer. So as far as diet, in general, a high animal fat diet puts you at a high risk of cancer, and then a high vegetable diet actually puts you at a less risk. So, or the other way to say is the diet low in vegetables also put you at a higher risk of prostate cancer. So, and then the other distinction is that the active ingredient, the lycopene, is usually not in the raw tomatoes. It's usually that antioxidant property is in some sort of a processed or cooked tomatoes. That's where you actually see that. And also there are other things that, omega fatty acids and fish oils, are slightly beneficial. And there's no association on some studies showed in the meta-analysis in 2001 that there's no relation between the risk with the alcohol intake and, there are like mixed results. You cannot say there's an association. And also the coffee apparently intake has a slight decreased risk. So, but the vitamins and minerals also puts you at a, mixed results, and definitely anything that is in antioxidant properties, selenium, folic acid, B12, all these things tend to have a, anything that is a antioxidant in general is anti-carcinogenic. So going into the screening, who are the ones who needs to get the screening? For men, generally speaking, the United States Task Force recommends having at least an average life expectancy of 10 years and above. So in general, the prostate cancer is a slow, occult, and slowly growing cancer. And so the two screening procedures is, during your doctor examination, you do a digital rectal examination. And then the prostate specific antigen, the PSA, is something that we often use also as a screening procedure. So anything less than 4 nanograms per milliliter is seen as low risk, and 4 to 10 is seen as a slightly higher risk, and anything more than 10 is seen as a significantly higher risk. And the prostate specific antigen is a very sensitive test, meaning that it has a very high degree of ruling in a cancer, but it does not rule out a cancer. Sorry, ruling out a cancer is very high, but not a great test in terms of specificity is pretty low. What I mean by that is, if the PSA is within normal range, you can safely say that they're much lower risk of having a prostate cancer. But if the PSA is high, there are so many things that would cause elevated PSA. Even a rigorous exercise, and then even if you do a digital rectal examination, and then following that, if you do that, then you actually can have an elevated PSA. The reason why this is important is, as important as it is to screen and identify the cancer at the early stages, sometimes if you have false elevated PSA, the next steps involved with that are, it's going to cause you to do a ultrasound guided rectal prostate biopsy. And then, of course, a lot of the cancers are slow growing. And then there are also the cancer treatments, which also has significant side effects, having difficulty to control your urine. So you kind of start this domino effect for a false positive. And so that's the reason why the risks and benefits has to be evaluated by your doctor in a clinical consultation. And as far as the symptoms, generally speaking, they have a difficulty urination. These are very urinary specific symptoms. And there are other symptoms, like you might have a small hematuria, which is blood in the urine, and there could be hematospermia right after having a sexual activity. You can have blood in the sperm. These are like the kind of non-specific urinary symptoms. And then also depending upon where the cancer it is, you might not even have sometimes symptoms early on. So especially if you have a cancer around the urethra, then you are more likely to have the symptoms. Sometimes if you have peripheral prostate cancer, it takes some time to become symptomatic. And so we do the prostate screening, and in general at this time the frequency is like every 2 years is what we recommend doing the testing. And I am actually doing the presentation from a primary care perspective. And as far as once the tissue biopsy is confirmed, so after biopsy you confirm the test, then we'll refer to the specialist, and the specialist usually oncologist and urologist or uro-oncologist. They do the treatment, and of course they'll explain all the procedures, and then PSA way to monitor that. So typically from a primary care perspective, once we identify a high risk patient and we refer immediately to the oncologist and the urologist, and once they confirm it, they start the treatment with surgery and chemoradiation. And then after the patient has undetectable PSA level, they subsequently send the patient back to the primary care. And then we actually continue seeing the patient. And in my personal experience, the one thing that actually has been associated with pretty much a difficulty is controlling the urine, up to the point where sometimes they wear the adult diapers. And that I noticed has a lot of not only inconvenience, it psychologically based on them, it's a big change in the quality of life. That's a huge, big change in the quality of life. And that's what we do, is that we include the behavioral therapy and the counselors to be involved in taking care of the patients in a multidisciplinary way. I know it's a very broad topic and very significant impact on the especially African American men. So I gave a brief synopsis, and I apologize if I missed any other significant points. Back to you, sir.
Thank you, Dr. Hari. And what we're going to do is, there are questions coming in, so we'll ask the questions after you all finish. So Dr. Catherine Glover Collins, if you could give us 7 minutes of insight and overview, I would greatly appreciate it. Thank you very much in advance.
Okay. Well, thank you. My name is Dr. Catherine Glover Collins. I am an assistant professor of surgery at Washington University in St. Louis. My specialty is breast cancer surgery. I went to undergrad at Xavier University and then medical school at Meharry Medical College. And then did my residency in Arkansas, which is my home state, and then came to Washington University to do breast surgery fellowship to just gain specialized training in taking care of breast patients. I have to give a quick shout out to my sorors of Zeta Phi Beta Sorority Incorporated. And I have to also give a shout out to First Baptist Church of Creve Coeur, Sister Jean Evans, for recommending me to come and speak with you all today. It's indeed a pleasure and an honor. And as we were kicking off Breast Cancer Awareness Month, I congratulate you ladies on taking on this task to help educate our city and the general population. So hats off to you all. Okay, so breast cancer awareness. And breast cancer in general. So breast cancer is usually, when you think about it, most people think it's just one disease, but it's more than one disease. And so when I see patients in my clinic, I try to take the time to go over their specific disease. And the first thing I always tell a patient is your breast cancer journey may not be the same as your sister's breast cancer journey. or your grandmother's breast cancer journey, or your neighbor next door. And so you have to really pay attention to what your doctors are trying to tell you and what they're recommending, and then take in what is good for you, and then make your decisions on treatment and or how you proceed. So that's the first thing that I want to say is that breast cancer is one name, but it is many diseases, okay? Any cancer that starts in the breast is considered to be breast cancer. It can spread to other places in the body, and usually if it spreads to other places in the body, it's considered to be stage 4. So anything that's before stage 4 is treatable. Anything after stage 4 is not. We know that breast cancer is the #1 cancer in women outside from skin cancers, and it is the #2 killer of women. And we also know that, as in all things, that African Americans are disproportionately affected and tend to present at later stages than our Caucasian counterparts. In general, a woman has a 1 in 8 or 12% chance of contracting or developing breast cancer at some point in their life. Usually it's in between the ages of 50 and 70. And typically you want to try to catch it early, and that's why breast cancer screening usually starts at around the age of 40. Now, there's always been some progress and things change in medicine as in everything else. And so maybe about last 4 or 5 years, the the screening recommendations have changed. It used to be you get your mammogram at the age of 40 every year. And we encourage you to do that at the same time of year so that you can stay on task. But guidelines have changed somewhat to include you can have it every 2 years after you discuss what is the best guideline to follow with your primary care provider. Some people will actually start their screening earlier than 40, and those are generally people who are considered high risk for breast cancer, and that can be people that have a large family history of breast cancer or ovarian cancer. And so those people are generally are thought to carry a gene mutation that causes cancer in their family. And then people who actually have the gene will be recommended to start their screening, some as early as 25, but mostly at the age of 35. In general, if you have a high cancer rate in your family, you are encouraged to start your cancer screening 10 years before the youngest person who had the breast cancer in your family. Okay. Risk factors for breast cancer. I always tell patients the 2 biggest risk factors for getting breast cancer is being a woman and getting older. Aside from that, things such as hormone replacement therapy, oral contraceptive use, not having children, not breastfeeding, those things all kind of increase your risk of developing breast cancer over someone who does not do those things or has children and breastfeeds. Treatment is a multimodal or a multidisciplinary sport. I always tell it is a team sport, and so we take care of you in a team. I'm usually the first person you'll see after the mammogram, and I try to coordinate your care. And then we'll talk about treatment a little bit later, so I won't go too far into that. In general, I say that breast cancer is a treatable disease as long as we find it early, and you take the recommendations that we give you. Is that good enough?
That was excellent, Dr. Catherine Glover Collins, Soror. I appreciate it and I thank you. What we have, I believe, Coretta has some questions that were asked. If we can go over those briefly, they came across the Facebook page. Coretta, if you would put those questions out there for us, please.
Okay, so this was for either Dr. Hari or Dr. Catherine. Is it true that diets high in grilled barbecue meats, utilizing charcoal, cause higher rates of prostate cancer in Black men? So I guess that's for you, Dr. Hari.
Got to unmute.
You're on mute, Dr. Hari.
I'm sorry. So yes, generally any burned meat in general has this nitrosamines that actually are formed, and then it not only puts you at a higher risk of the prostate cancer, even like cancers like GI cancer is also very common when you actually have any meat that is burnt. So the burnt meat definitely puts you at a high risk of having the cancer, and also in general, even a diet very high, even in a well-cooked animal fat, high in animal fat diets, and also low in vegetables also definitely would put you at a higher risk. The answer is yes.
Can I just put in that I always tell my patients, when it comes to diet, moderation is everything.
Yeah.
You can eat some of these things, but every day, all day is probably not a good idea. So moderation, everything in moderation.
Thank you so much for clarifying that. I just want to add one thing. When one time I was counseling a patient about diabetes and about the carbohydrate intake and things like that, and I did not clarify that, and he completely stopped eating all the carbohydrate. So thank you so much, Catherine. I really appreciate it. And Dr. Collins is absolutely right. We have to do it in moderation. I'm not saying just don't eat any meat, period. That's not what I'm saying.
Okay, so we have another question. It was mentioned earlier, cooked tomatoes have higher amounts of lycopene. Lycopene. What foods are higher in antioxidants and selenium, which are good for fighting cancer?
So I'll also yield to Dr. Catherine to comment on that. So generally, vitamin E at 400 units and above is something that has been traditionally considered as a good antioxidant. And of course, as you mentioned, selenium. And then the lycopene is a very active ingredient. And like I had mentioned earlier, you want to make sure you cook the tomato. The raw tomatoes does not have the active ingredient lycopene. So for example, a ketchup actually does have the active ingredient of the lycopene. And so vitamin E, so if I can take one step back, and you know, Dr. Collins can also add into that. Your body naturally makes these free radicals, which actually are, you know, superoxides and these chemicals that put you at high risk of having cancer. In all of us, we normally have the cancer cell that forms when your body is trying to regenerate. But what we have is we have this kind of a self-autocorrective mechanism that's driven by the T lymphocytes, where it identifies something that is wrong, and these cells will go and kill these natural killer. They're called the natural killer cells. They'll go and identify the cancer cells and kills them. So in general, as the free radicals and are considered to be carcinogenic, so anything that is high rich in antioxidants would automatically put you at less risk of cancer. And then I can even take it one step further, and also they're good for the heart too. And one thing I forgot to add is I'm the Chief Medical Officer at KRSTL Health. And then also I'm a cardiologist. I'm a heart specialist as well. So these are very good for both the heart and definitely for the cancer. Dr. Collins.
No, I think you explained it very well. Basically, antioxidants help us fight cancer, help our body boost our immune systems to fight the cancer. I believe cranberries is also a good source of antioxidants. Mainly your fruits and vegetables are your best source for most of the things that we need to help us fight the diseases of the world.
Thank you, doctors. As we move along, and please don't go anywhere, thank you very much. It's very informative for me as we go. Very informative. I need to change some things. Okay, really. As we move along, we're going to go into the testing experience. And what we have is two individuals that can really verify what they've gone through in the testing experience. We have Adrian Gaines and Dr. Mark Hewitt. And Adrian, if you could take 7 minutes just to give us some insight, and Dr. Hewitt, you'll go after that. I would greatly appreciate it. Thank you for your time.
Very good.
Good evening, and thank you for this opportunity to speak about my own personal testing experience for breast cancer. I was diagnosed with breast cancer in 2015. I had what they call I think it's carcinoma in situ. I had scheduled a mammogram because of the symptoms and changes that I had noticed in my breast. I had also missed my regularly scheduled mammogram, and I was like 6 months overdue for that. I might say for years I had had a very small cyst in my left breast, and each time I had a mammogram, I would be given an ultrasound, and there was never any problems. Well, as I had expected, when I took the mammogram, it would show the growth, and I also knew that I would probably receive an ultrasound. And but this time it did confirm that there was a suspicious mass. So the next step, a few weeks later, I had a fine needle aspiration biopsy done, and a small amount of tissue was taken from the area and removed and tested. I later received, maybe about 2 weeks later, a letter with the results, and the findings were at that time that there was no cancer. So of course I was relieved, but I was still concerned because the symptoms that I'd never had before, that I'd never experienced before, seemed to indicate to me that something was wrong. So several weeks later, I received a call to come back for another breast biopsy. This time I had questions, and I had my husband to accompany me to the appointment because both of us could listen at the same time. So I met with a surgeon, and she explained to us that I would have a surgical biopsy. This time I really started asking questions like, what happened to the other findings, and how did you come up with this new information that now leads to you want to do a surgical biopsy? And in all honesty, I really never got any questions, but that was just my part. The only problem for me with the surgical biopsy was that I had to be given some type of anesthetic to go to sleep, and I'm allergic to different things. So before they could even do that, as we followed this procedure, I had to go to an allergy clinic and do some testing to see what would work. So by now, I'm like 2 months into this situation, and finally I was cleared and they found out what would work, and then I had the biopsy. It was, rather than a biopsy, I found out later that it was a lumpectomy, and the entire mass was removed at that time. So I had to wait another 4 weeks for that incision to heal before I actually returned to see the surgeon, who explained to me what had been done during this procedure. Then the surgeon told us that I would have to have a mastectomy. Now, that's when I really got surprised and started asking questions. She explained to me that the type of cancer that I had, if it were not removed, it would spread to other areas of the breast. So to keep the cancer from spreading, they would remove the entire breast, and also 2 of my lymph nodes under my left arm were removed when they were doing the final surgery. So the final surgery was scheduled on February the 28th. And that at that time I did have my mastectomy. The entire process took about 4 months from the time I had the mammogram in October of the previous year. I am thankful that I did not have to have chemo or radiation. All I do now is take a very small pill every day for 5 years. I have 1 more year left to take what I call my cancer pill. This particular pill lowers the chances of getting cancer in your other breast. I would strongly suggest to anyone to make sure that you become informed about what's going on in your body, and insist very strongly for answers regarding all the information and why certain decisions were made or are made regarding the findings. Of course, if you're not satisfied with what you hear, I would also suggest that you get a second opinion. Back to you.
Thank you. Thank you, Ms. Gaines. You're a trooper. Thank you, and God bless you. And I know it's already done. Dr. Hewitt, if you could take the time, my frat brother, give us 5 minutes of how your testing experience was.
Brother Jordan, before Dr. Hewitt jumps in, can I just say a couple of things that came to mind while it's still fresh on my mind from Sister Gaines?
By all means.
So one of the things that I love that she said was that she saw some symptoms that were different from before, and she scheduled her test. The first thing I always want to say is when you see symptoms, seek medical attention. You know, I have a number of women who come through my clinic and they say, well, you know, I felt this lump 6 months ago, but I knew I had a screening mammogram. I had to wait to my screening mammogram in November. So that's why I waited so long. If you're having symptoms, you need to get into your doctor so you can get this looked at. Sometimes it won't be cancer, but we won't know until we have the imaging and the biopsies that are necessary. So I love that Ms. Gaines told us symptoms equals seek treatment, okay? Second thing is she said that she had always had cysts before, so she knew that, you know, it was a possibility she would have to have additional testing. You can't always assume that what you've had before is what you're gonna have this time. So every new symptom that you have, you need to get it checked out. And then finally, you were saying that you thought you were going in for a biopsy and it turned out to be a lumpectomy. Those are just semantics. In surgery world, breast surgery world, if we're going in to figure out what it is, it's called a biopsy, even though we're taking out a lump of tissue. But if we know we're going in for cancer, we call it a lumpectomy from jump. So it's the same surgery, it's just different reasons why we do it. Okay? And those are just some of the things that came to mind. Thank you.
Awesome.
Thank you, Dr. Collins. Brother Hewitt, and very informative, very informative.
All right, thank you. So of course, I've been tasked with sharing my experience with prostate testing / screening. Of course, there, as Dr. Hari suggested, that there are several testing methods that physicians utilize, but our discussion will be focused on just two, the PSA test and the digital rectal exam. In January of 2018, I had a routine PSA blood draw performed at my doctor's office. And I'll just break down what the PSA is. It's a prostate-specific antigen. It's a protein made by cells in the prostate gland, both normal cells and cancer cells. The PSA is mostly found in semen, but a small amount is also found in blood. The PSA level in blood is measured in units called nanograms per milliliter. As Dr. Hari suggested, most men without prostate cancer have PSA levels under 4 nanograms per milliliter of blood. When prostate cancer develops, the PSA levels often goes above 4. So I want you to keep those numbers in mind. The key number is 4 nanograms per milliliter. So in January of 2018, I had a routine blood draw, and my PSA level at that time was 1.7 nanograms per milliliter. Middle of the year of 2018, in June, my fraternity brothers and I had what's called Sigma Dad Day, where we had brothers come in and have PSA levels, PSAs drawn, blood drawn, to have their PSA levels checked in the middle of the year, around Father's Day. We've done it every year since. It's called Sigma Dad's Day. In June, I had my PSA level checked again, just routinely. I thought because I had my PSA level checked in January, that in June, I didn't have any worries, to be honest with you. Well, several months later, I got a phone call from one of the volunteers that actually drew my blood. And I was told that my PSA level at that time was 5.6 nanograms per milliliter, which is of course above the 4. It concerned me, of course. And so I made an appointment with my primary care physician. And at that time, I had a digital rectal exam performed. The digital rectal exam, of course, was performed in the office. The physician was gloved, went into the rectal cavity and felt that my prostate was a bit enlarged. There are 5 lobes in the prostate, but 2 lateral lobes that he was checking, and he could not feel the sulcus in the middle. And so he saw that it was enlarged. And as a result of that, he sent me to a urologist specialist. And in October of 2018, my PSA level came back at 8.8 nanograms per milliliter. So, of course, it was a significant jump. And as I went through the process of seeing the urologist at that time, I had what's called a prostate biopsy. And of course, Dr. Catherine has talked about breast cancer biopsies and things of that nature, but for the prostate biopsy is a little unnerving, to say the least, for me, for any gentleman that's ever had it done. It was definitely unnerving for me, but it was a necessary evil, I would say. Because at that time, what happens is a core needle biopsy helps to give the urologist an idea. Really, the urologist took some samples, about 12 samples from my prostate. He had to go through the rectal cavity in order to get those samples from the prostate with a needle. And of course, you can just imagine how that wasn't really comfortable at all, but it was necessary. So I had that done, and by November of 2018, I was diagnosed with prostate cancer. Within a month and a half, I had surgery to have my prostate removed. But that's where I'll stop at this time for testing, and I'll pick it back up with the recovery later in the segment. Back to you, Brother Jordan.
Thank you, Dr. Hewitt. Thank you, Ms. Givens. Very informative, and that can be bone chilling, those experiences. And I can tell you that from experience in some aspects. As we moving forward, we're going to treatment, and we'll go back to Dr. Hari and Dr. Catherine Glover Collins. And Dr. Collins will ask you to go first. If you could take 10 minutes just to give us some information, some insight on treatment. Thank you. You're still on mute. There you go.
I got you. Okay. So typically when we talk about treatment of cancer, it's going to be 3 things that may or may not happen. It's going to be some surgery. It's going to be maybe some medications, or what we call systemic therapy. And in breast cancer, that is in 2 forms. So Ms. Gaines already told us she takes a pill it's an estrogen blocking pill. So a lot of women who, about 80% of breast cancers actually are fed by hormones that our bodies produce. And a lot of women that say, well, I've gone through menopause, I'm not making estrogen anymore. Well, actually we do, even after we've gone through menopause in some small amounts. And so if your breast cancer is fed by hormones, you'll be recommended to take an anti-estrogen pill for at least 5 years. If you're one of the young people that gets diagnosed with breast cancer, you will probably be recommended to take it at least 10 years. And then the other type of systemic therapy we have is chemotherapy. Now, some people will even be told that, yes, you need to take the pill and have chemotherapy. And again, that goes back to what kind of breast cancer do you have? If you have a cancer that is going to respond well to chemotherapy, then you should have chemotherapy. There are a bunch of different chemotherapy regimens for breast cancer. And so some people will go once every month for 4 months and then be done. Some people will go and have injections for a whole year. And so the different types of chemo regimens are determined by a medical oncologist, and they make the best recommendation based off of what kind of breast cancer you have. The other types of breast cancers out there are the triple negative that some people might have heard of. And that's basically because there are 3 receptors that we look at for breast cancer. The estrogen receptor, progesterone receptor, and the HER2 receptor. If you don't have any of those on your cancer, that's a triple negative cancer. And that is only treatable by chemotherapy if it's a certain size, okay? And then there's one that's HER2 positive, and those need chemotherapy as well, in addition to those injections that you take for a whole year. And that's just briefly what you get for systemic therapy. And then the other treatments that are involved is in radiation. Whether or not you need radiation depends mostly on what type of surgery you have. And I'll dive deeper into surgery in a second. But radiation depends on what type of surgery you have, but also can depend on whether or not you have lymph nodes that are positive for cancer. And so that's why we do those surgeries, especially when we do mastectomies. We want to take out lymph nodes because we want to have that information to know whether or not you need radiation. Radiation typically lasts for up to 7 weeks, and it's a Monday through Friday. So 5 days a week for 7 weeks. That's the longest anybody would ever ask you to go to radiation therapy. But there are some women that only go for 1 week. Some women that go for 3 weeks. Some women that go for 1 shot and done. So radiation therapy is determined by a radiation oncologist, and they take everything about your cancer into account, and then they decide how much radiation you need and for how long. When it comes to surgery for breast cancer, you have 2 choices. You have a lumpectomy and you have a mastectomy. And generally, most women, if your breast cancer is caught on a mammogram, you truly do have a choice to make, because one surgery is not better than the other for a small cancer, okay? And I say that because your survival is not based off of whether or not you have, what type of surgery you have. Your survival is based off of what your stage of cancer you have, okay? Some women will say, well, I'll take that mastectomy because I don't want to ever go through this again. I don't want to ever get breast cancer again. But every person that has ever had breast cancer will tell you there's always a chance that breast cancer can come back. And so taking off the entire breast doesn't mean that you won't have to go through it again. It just means that the chances of it coming back is a little bit smaller than if you had a lumpectomy. From a surgeon standpoint, a lumpectomy and a mastectomy are the same in terms of recurrence rates and in terms of being able to get rid of the cancer, okay? Whether or not you are offered a lumpectomy depends on how small your cancer is versus how large your breast is. So, and I always say, if you have a walnut-sized breast cancer and a cantaloupe-sized breast, you can take that out, no problem. You won't miss it. Nobody will ever see that you have a dent or anything like that. But if you have a cantaloupe-sized cancer and a cantaloupe-sized breast, I can't remove that and still leave your breast behind. And so for some people, they will have large cancers across their entire breast or cancers in multiple spots of their breast. We can't remove all that cancer and leave you with something that you would be happy with. And so that's usually when we recommend a mastectomy. I do have women that have aggressive cancers or later stage cancers that are able to get lumpectomies. And that's usually after they have had some type of chemotherapy up front to shrink the cancer down, and then we're able to do a smaller surgery. Okay, let's see. The difference between a lumpectomy and a mastectomy. Lumpectomy is usually an outpatient surgery. The chances of breast cancer coming back is about 5 to 10%. You usually do need radiation if you get a lumpectomy. And the cosmetic result is usually more appealing because you do get to keep the breast, and usually you can't tell that you've had surgery. With a mastectomy, you spend the night in the hospital. Most people go home the next day. I even have some partners that are starting to explore doing outpatient mastectomies. So you go home on the same day as your surgery. You typically don't need radiation after a mastectomy but there are some women that will, and I kind of alluded to, those are the ones that have lymph node involvement. And basically you don't get to keep the breast, but you do have the option of reconstruction for most women. And I say that because there are other factors involved, like diabetes, people who smoke, people overweight. They're generally recommended to do some life factor or lifestyle changes in order to be able to qualify for reconstruction. But you do have to, your insurance company does have to pay for symmetry. So reconstruction is considered to be a symmetry procedure, or some people will elect to have both of their breasts removed for symmetry. The only time that a surgeon really recommends doing a mastectomy is for women who have genes that cause breast cancer. And it's more beyond just the BRCA1 and BRCA2 that you might know about. And so oftentimes, if you have been diagnosed with breast cancer, especially if you're under the age of 60, you'll be recommended to do some genetic testing to help us better figure out how to take care of you. And that's it.
Thank you, Dr. Glover Collins, excuse me. Very informative and enlightening. I have 6 sisters, so it really captured me. Dr. Hori, thank you. You can go right ahead.
So first I want to kind of, elaborate. Thank you so much for Dr. Hood for sharing your experience. And I must say that you are lucky that you had that intermittent testing, and generally that's not what we normally do. And I'm so glad that you had that extra testing done. And the significant point to highlight there is following the trend of the levels. Don't ever get comfortable, because if you look at the story that Dr. Hu shared with us, if you look at both of those numbers individually, they're not in the huge danger zone, so to say. It's usually more than 10 is something. But the striking thing is, in such a short span of time, he went from like 1.6 to 8. So if you had only those results with no other, what we call a sequential correlation, then you would be like, well, probably not high risk. So that's number one. And number 2, to add to your very uncomfortable and very unpleasant experience of that biopsy, what is that they're trying to do is, they know that inside this prostate gland somewhere, there is cancer. So it's almost like trying to pick like a needle in a haystack. So the more punches they do is the more they capture it. And there's a high likelihood they would actually capture it. That's the reason why typically they go 12, and then I have seen some rare cases where they go up to like 16. And let's say if they got good, nice core biopsies of even 8 and 10 samples, I have seen them back off also, because clinical exam, they usually do exam before they actually do the biopsy. And they usually take an ultrasound to guide them to get the right spots. They can actually get to that. So that's number one. And the one important thing, if there's one thing, if I could leave to today as a take-home point, any elderly man, especially in the high-risk group, if you ever have an unexplained new onset back pain, please always make sure you rule out the prostate cancer, because I have had multiple experience way back in the day in the Caribbean. I did some surgery. So that's why I saw a lot of them over there. So if let's say if you look at the statistics, the back pain is extremely common. I mean, if you talk to anybody, the question that was asked in a survey is that, did you ever have a back pain once in your lifetime? They said, yes. And almost 100% said yes. So it is very, very common. But what I'm talking about is that you have your regular back pain. And let me actually share one real clinical history that somebody came to me. I had a patient who came for a routine back pain, and as an initial chief complaint, we went and did the back pain workup. And then in 2 weeks back, he could not even walk. He's already kind of, walking with difficulty. And I immediately knew something was off. And again, I had some prior selection bias with all these things I had seen in the past. And I not only did further radiological investigation, but I went into the PSA. So just to highlight, his PSA came back as 184. And I spent 90 minutes on the phone to get that patient an appointment the very next day to be seen in the oncology department, because that's where I'm going to transition into the treatment. Whereas once you have a tissue biopsy that is confirmed by a pathologist that this is actually a cancer, in general, they actually do this thing called the Tnm staging. So they see what is the size of the tumor and what is the characteristics of the tumor, and then they look at what is the regional lymph nodes that is involved, and then also then find out whether there is a metastasis or not. So typically, like your infection, the cancer through the lymphatics would go to the local regional lymph nodes. That's why in the whether it's a breast cancer or prostate cancer, they look for the regional lymph nodes and see if the lymph nodes are involved. So when we send to the specialist, they usually use the staging, and once they do the staging, they kind of decide the treatment. And like Dr. Collins has alluded to earlier, generally speaking, it falls into the three categories: surgery, radiation, and chemotherapy. So surgery, you always want to take out the source of the problem. So that's why you always will go for resection if you can. I mean, no matter what other treatment you do, if you kind of leave, there would be some difficult stage 4 bone metastasis. They get whole body radiation, and this cancer is so widespread that it is so difficult to do surgery. But generally, as a rule of thumb, you always want to get the source of the problem. Take out the tumor, take out the cancer causing problem. And then in prostate cancer, they do a radical prostatectomy. And of course, based on the stages, sometimes, they can go and take the focus to the lobe that is involved, or sometimes they actually go wide resection. And then the patients who usually get a wide resection are the one where they have a lot of complications subsequently, where the prostatic part, your urethra, where you pass your urine through, goes through your prostate, and we call that prostatic urethra. And that is where there is a sphincter there that helps you to hold the urine inside. When you do a wide resection of prostate, then it is so difficult to kind of hold your urine, and then they would be the one who has this unfortunate problem of not being able to hold the urine. So once the surgery is done, they will also do radiation therapy. Sometimes they do brachytherapy, where they actually put the target location and then use the radiation on that. And then of course we actually use anti-androgen, which is actually that suppresses the androgen. And in some cases, they even do extreme cases, when it's very, very widespread, and castration is one thing that's very extreme. That's not something I have seen. But these are the three modalities in general that we use. And in particular, for any cancer, we want to have a multidisciplinary approach. And then one of the big thing, especially the prostate cancer, the complications, like I just alluded to, if we don't do a proper selection of the candidate and do a proper decision at the very front end, you might go into this route of actually subjecting the patient to get all these tests, and then also the treatment, because not every cancer of the prostate, usually they go and do aggressive treatment and surgery. There are some very low risk patients. And also, let's say, for example, somebody got diagnosed with a prostate cancer at 75, and if they consider it an initial approach to a low risk cancer, they would do what they call active surveillance and monitor very, very closely. But in general, the younger you are, the aggressive you want to be, because the life expectancy is really long. So you want to make sure you get it out. And one thing I'm happy to say is that the medical world has made a significant progress, especially in all the cancers, and of course the prostate cancer. And you will see a lot of men living decades of life even after being diagnosed with a prostate cancer. So early surveillance, be on the lookout for the symptoms, especially the atypical symptoms. And the older you are, the higher risk you have, your immediate family member, and go and do the testing. And generally speaking, one thing, if I may add to Dr. Howard's experience, is that I always do the PSA test before I do the rectal examination. Because if you do the rectal examination, it falsely raises your PSA, sometimes more than 10, and then you're subjecting this patient to this very uncomfortable procedure.
Absolutely.
Okay, so we do have one question for Dr. Glover Collins. If a benign mass is found during a routine mammogram, is that cause for an alarm?
Typically not. It really depends on how it looks on the mammogram. And so the radiologists have this system called BIRADS, and not to go through every single one of them, but they look at how does this mass look on the mammogram, and then if they see a mass, they'll also do an ultrasound. And putting those two things together, they can say, what's the likelihood that this is something cancerous, or what's the likelihood that this is something benign? If they can say without a shadow of a doubt that it's something benign, they'll give it that benign rating and you're good to go one more year before your next mammogram. If they think that it's probably benign, but it's their first time seeing it on the mammogram, they'll recommend to bring you back in 6 months so that it can take another look at it. If it changes, then you'll go into the biopsy category. If it stays the same, they say come back in another 6 months so we can keep looking at it. And typically it takes about 2 years before they can downgrade it and say that not only do we think it's probably benign, but it is benign because it's not changing any. Okay. If at any point it changes and becomes more worrisome looking, then you're pushed to biopsy. Now, Ms. Gaines had a very special account in that her first biopsy came back benign and she thought she was in the clear. But what happened was what I would venture to say is that once the radiologists looked at the pathology and on their list of things, how suspicious are we that this is cancer? They said this benign result doesn't really match what the characteristics say that it should be. And so that's when we usually get sent to a surgeon to have a surgical biopsy or to take the whole thing out to have a better examination to figure out what's going on. Sometimes they're at the very edge of the mass and they don't get a good sample. And sometimes it's just really hard to be able to make a diagnosis off of a small piece of tissue. And sometimes they need the whole thing.
Mhm. Thank you, Dr. Glover Collins, and both of you for sharing such informative information about the treatment process. So now we're going to come back to a couple of our members and allow them to, again, share their experience. We have Constance Carter, who will be sharing her recovery process, and then we'll have Dr. Hewitt come back and talk about his recovery process. Thank you.
Okay, good evening. My name is Constance Carter, and I am the chairperson for Target 2 Breast Cancer Committee. And I have to say, listening to Dr. Glover took me back, all the way back through all of the things that I experienced. The first bout of breast cancer that I had was in 2006. I had a mammogram done at my job, and I was so used to them coming back negative that I almost didn't open the envelope. And when I did, I was told that, they found something abnormal and they wanted me to come in. So I was like, okay. And there happened to be another coworker of mine who received the same result. So I'm encouraging her because she was scared to death. Long story short, hers was fine. Mine wasn't. So I had the biopsy, the needle biopsy that came back, which led to the lumpectomy. I actually had 2 lumpectomies, and my surgeon told me that she wanted to do a mastectomy, and I almost fainted. And I'm like, she explained to me, she goes, well, you don't have any breasts left. And, I'm looking at my breast and I'm like, yes, I do. And she's like, no, the tissue is like gone. She said, we have to do this mastectomy. She said, because she just wasn't satisfied. She felt like there was still something there. So after that first mastectomy, she told me that the cancer was in the nipple. She said it was like, it was so small, like if you drop sugar on the table, that's how small it was. And that's why she wanted to do the mastectomy. So I had the mastectomy done, and then I had to decide whether I wanted to, have reconstructive surgery. Long story short, I chose to have the breast implant because they had just, at that time, could choose between the silicone or the saline. And they were Washington University was just bring in the silicone back. So I chose the silicone breast implant, and the whole process started in October. I didn't get finished until the following, till July, because I had to have the catheter implanted to stretch my breast for the implant. And the reason I went with the implant, because I thought, they told me, well, that surgery was only like an hour and a half, versus if I use some of my skin, that could be like a 8-hour or longer surgery. So I went with that. And the recovery process for me with the implant, I think I was off work for about a month, and I had my family. My mother was moved in with me, and that process went pretty smooth. And I was put on tamoxifen for 5 years. Next thing, 2000, I don't want to say 15, 16, it was almost 10 years to the date. I noticed that the breast with the implant was getting bigger. And I thought that, I was doing more chest exercises, but also taking fish oil. And I thought, well, maybe it's the fish oil. Something, is wrong. And we were going to a regional conference in Chicago, and I had mentioned it to some of my sorors, and they were like, yes, Connie, we can tell it's actually so big that it's sticking out. Your breast is like really showing through your blouse. And they was like, I said, well, okay, I'll contact my doctor as soon as I get back to St. Louis. I called my oncologist, and he couldn't see me right away. So I contacted my gynecologist, and I went to them, and I explained to the doctor that I thought it was because of the fish oil. And they were like, no. They reached out and they said, we need to get a mammogram right away. So they did like, not a mammogram, but they did like x-ray, because they thought maybe the implant had ruptured. So they did an MRI. Come to find out, the MRI was intact. I mean, the implant was intact, but it was a lot of fluid around the implant. Then the doctor told me, they said, we're going to have to do surgery because to remove this implant. They removed the implant, and I was told, or they told my mother, that out of 200 people in the world, my body rejected the implant. 10 years later, my body rejected this implant. So they had to remove that implant. And so I went, I had to wait 6 months, I was told, before they could do anything else. And in between that time, I was scheduled for my regular mammogram on the breast that I thought was okay. I went and had a mammogram on that breast, and I was told that it was abnormal. And I had to have a biopsy. It came back cancer. So at this point, I didn't know what to do. I was, at my wit's end. Long story short, when my oncologist was like, well, we're going to go, tell me the different treatments, I was like, not again. We're going to just get a mastectomy. I'm like, I'm not going through the whole process. I'm like, just take it, So they scheduled the surgery. Now, I thought, okay, because I had went through the first surgery, even though my whole plan was to avoid this 8-hour surgery, I ended up having to have it anyway, because I could not get any implants, because the implant that I got in 2006, they said that was the latest one. So they said I could never get another implant. So they had to use my own tissue. And I chose to take it from the abdomen. I thought, okay, that'll be pretty good. I'll get a tummy tuck, the whole works. What I didn't know was, not only was it a long surgery, I didn't stay in the hospital that long, maybe like 2.5, 3 days. And then I came home. But the recovery process took forever. I mean, it took forever. I want to say from September, by the time that I got to Thanksgiving, I was barely at like a 45-degree angle as far as being able to stand. And I had the support of my sorority sisters and my family. I needed someone there constantly, because I had to learn how to do everything again. I couldn't stand up for the longest, and parts of your body that, they just go numb. And I was told that some feeling would come back and some wouldn't. And to this day, I still have numbness in areas. I might get an itch and you go to scratch, but it doesn't do anything because it's an internal itch and you can't feel it. But the whole process, and I had just got to the point with the first surgery where I got to a point where I was no longer having to take the tamoxifen. And then I was told that I would have to start all over again with another chemo pill. And then my oncologist goes, I don't know, I may think about radiation. I was like, no, we can't do radiation. I just had the mastectomy. I'm thinking that should have taken care of it. He said, well, we'll see. We'll start you off on this chemo, but if you have to later on, you may have to have radiation. But thank God I never had to have radiation. I never had chemo. I just had the double mastectomy and living through that recovery process. And that's pretty much it.
Thank you for sharing, Dr. Hewitt.
Oh, wow. Connie, I'm glad you're with us. That's for sure. That was a, wow, heroic story. So with my recovery, and I'll just mention that, as Dr. Hari mentioned, Caribbean men, my father is from Panama, but his parents were from Barbados. And so I don't know, my father had prostate cancer later in life as he got older. And then, of course, here I am in my 40s with prostate cancer. But nevertheless, I went ahead with the surgery. I had surgery, I had the robotic surgery, and I had my prostate removed. And as a result of having my prostate removed, it comes with a lot of complications. Well, I wouldn't say complications, but it comes with definitely a lifestyle change after the surgery. Essentially, prior to the surgery, I was told to do Kegel exercises, and for men, of course, Kegel exercises to help strengthen my pelvic floor. And the reason why is because essentially when you remove the prostate, as Dr. Hari suggested, you have a sphincter that helps to hold the urine in. The prostate actually sits right below the bladder. And because it sits right below the bladder, it has its own valve, so to speak. And once it's been removed, you no longer have that valve to hold urine in place. And so one of the most, biggest concerns that I had once I had my prostate removed was being able to hold my urine, which was pretty tough. And so I had to do these Kegel exercises and learn to, hold my urine in place. And I did those Kegel exercises every single day because for me, it was just embarrassing to go to Target and have to pick up the pins to wear. It was just the male ego in me or whatever, but it was just a tough thing to do, but I had to do it. Because if I didn't, I would have soiled my underwear, and there's no question about that. And I didn't want to have that happen. But anyway, the recovery period took about 3 to 4 weeks or so after the surgery. I remained at home. I tried to relax and change my diet as best as I could. The other thing that comes with prostate surgery and the removal of your prostate is the fact that you're no longer able to have kids. The prostate itself helps to produce, is in the process, it helps to produce semen. And once it's been removed, your body can no longer produce the product to produce children. And so that was a difficult thing for me to wrap my mind around as well. In addition, the other huge component that comes with the removal of the prostate is erectile dysfunction. That is just a flat out, a reality that men have to face when they have their prostate removed. So you have the combination of urinary incontinence, you have the combination of erectile dysfunction. A lot of those things mentally can really just be draining on a man. And so you have to be able to work through those things. You have to talk to your doctor, and a multidisciplinary approach is definitely important. And so what do? 4 weeks out after surgery, the next thing you do is you go to your urologist, and he's going to ask you, how is your urinary incontinence? He's going to check your PSA levels to make sure that they're almost, there's no trace of, PSA level. And he's going to provide you with either Viagra, Cialis, Levitra to help with the erectile dysfunction. And sometimes those medications may or may not work. And so then you have to go to the next step, and there may be a trimix of a penile injection to help with, erectile dysfunction. And so those are just the realities of having prostate cancer. Now, during the prostate removal, what happens is that there are bundles of nerves that are attached to the prostate that help with your erection. And I had what was called a nerve sparing procedure. And so some of those nerve bundles were preserved in my particular case. Now, for some men, sometimes the cancer can attack those nerve bundles, and they may not ever have the ability to have an erection again. Thankfully, in my case, that is not the case. Those nerves were preserved for me. So there is a phrase that some doctors will use with regards to erectile dysfunction for men that are kind of struggling. And I'll just say this right out loud. You have to use it so you don't lose it. Use it so you don't lose it. And that's important. You have to, with your partner, have a good working relationship to kind of figure that out on that level. But with regards to everyday life, of course, my urinary incontinence is gone. I'm here. It took about, I would say, roughly maybe about 3 to 4 months for me to really feel comfortable without having to use Depends. It took about that long. But eventually, I was able to do away with it. But that's been my story since having my prostate removed. It's definitely a lifestyle change. There's no question about it. It changes, it turns your life upside down, and you have to be able to kind of roll with the punches. I know that Dr. Drake, in her conversation, which is coming up next, she's going to talk about some resources for men and for women with regards to cancer, breast cancer and prostate cancer. But then also, we have a good brother, Brother Ira Hughes on the Zoom call. He's going to take the place of Mark Cruz, and he's going to put out a challenge for the brothers of Phi Beta Sigma and beyond into our community. And I hope that what we've talked about tonight has, helped someone or helped a loved one, because cancer is no joke, and it can attack you without notice. It's in some sense, it's the silent killer. And so I'm hoping that what we've talked about this evening has resonated with someone or a lot of people on our Facebook Live and beyond, into YouTube, and because I know that this is going to be archived, and so people are going to be able to view this video over and over again. And I think that's a beautiful thing for us to capture these moments so that it'll live on beyond, past us, to help others. And that's most important. And thank you.
Thank you, Dr. Hewitt. Look, Connie, Adrian, Mark, my prayers go up for you. Thank you for sharing, first and foremost. I know it's not an easy thing to share. I've had my scare, I've had a biopsy and my test came back negative, and I can tell you, just to receive that phone call when my doctor first called me was something I'll never forget, because I had just retired from the police force. But what I will say is it's people like you that give inspiration, because a lot of times when we hear cancer treatment or you're going to go through, a lot of people start talking about, will I make it? And I do believe your mental aspect and your strength, your will to fight plays a large role in that. So thank you very much, because you all are inspirations greatly. And as we move forward, we're going to talk about resources with Dr. Bettina Drake. Dr. Drake, I'm thanking you in advance, and I'll thank you afterwards as well.
Oh, of course. Well, thank you for having me. I want to thank my soror of Zeta Phi Beta Sorority, Dr. Stallings, and my brother, Dr. Hewitt, for inviting me to be on this panel, and my colleague, who is also my soror, Dr. Glover Collins. I'm very excited to be here this evening. I'm Bettina Drake. I'm a cancer epidemiologist at Siteman and Washington University and the School of Medicine. And I do cancer prevention and cancer disparities research. And so what I wanted to talk about tonight is resources in terms of cancer prevention and cancer prevention strategies. And I'll talk about some resources for screening for breast and prostate cancer when I get to that, that topic. So for cancer prevention at Siteman, we talk about 8 ways to prevent cancer. And there's a lot of research that's gone into what can we do to prevent cancer. And some estimates say that up to 50% of cancers can be prevented. And of course, there is still a significant percentage of cancers that can't be prevented, even if you follow all 8 of these guidelines that I'm going to talk to you about. So the first is maintaining a healthy weight. We know that overweight and obesity is a huge problem here in the US. But research has found that overweight and obesity is also associated with developing several cancers, including breast and prostate, breast and colon and pancreas. Some research has shown that risk of breast cancer dropped by 60% in women who lost more than 22 pounds after menopause, and a loss of just 5 pounds of weight can lower that risk by 15%. And so we all know what to do to maintain a healthy weight, you know, keeping your weight in check. And for many, it's not about focusing on losing weight, but just maintaining your weight and focusing on not gaining additional weight, particularly as you get older and post-menopause. So eating a diet rich in fruits and vegetables, exercise, all of those things that you know. The second tip for cancer prevention is exercise. And so thinking about exercise, not in terms of losing weight, but exercise in terms of getting your heart rate up and releasing all of the other positive properties within your blood that can help fight cancer. And so we know that exercise is one of those preventative preventative behaviors for reducing your risk of colon cancer. The third cancer prevention behavior that I want to talk about is to not smoke. So we all have heard that smoking increases your risk of lung cancer, but actually smoking increases your risk of 11 different cancers. So smoking increases your risk of multiple types of cancers, including stomach, kidney, pancreas, esophagus, bladder. And in total, it can attribute to over 30% of cancer-related deaths. So for if anyone does smoke, the message that I want to get across is that it's never too late to quit. Like even if you've been smoking for 20 years, it's not too late to quit. You can still reap some benefits, health benefits. And even within a few months, you will start to see health benefits, not just for cancer prevention, but for other chronic conditions as well. The fourth cancer prevention tip is to eat a healthy diet. And I think there were some early questions on what types of foods can you eat in order to prevent cancer, or foods that might increase your risk of cancer. Dr. Hari talked about tomatoes and the lycopene and how it can reduce your risk of prostate cancer. We talked a little bit about red meat and how it's associated with an increase of colon cancer and prostate cancer. But we do know that berries rich in antioxidants, which we talked about earlier. And there have also been some studies that talked about the positive benefits of vitamin D in breast cancer. You can get vitamin D from milk, you can get vitamin D fortified orange juice, you can also get vitamin D from dark leafy greens like collard greens, kale, other vegetables like that. The fifth risk cancer prevention behavior that I want to talk about is drinking alcohol only in moderation. So we know that, I don't know if Dr. Hari will disagree with this, but studies have shown that red wine can have positive benefits for the heart. But drinking too much alcohol can increase your risk for some cancers, like breast cancer and colon cancer, as well as head and neck cancer. So again, in moderation, you don't want to overdo it on any of these risk behaviors. The sixth behavior is protect yourself from the sun. And yes, even for African Americans or those of us that have more melanin in our skin, protecting ourselves from the sun is still very important. Wearing sunscreen when we're going to be outside for extended periods of time is still very important, because it's less likely for us to have skin cancers, but it is possible. And so it's something that even those of us with more melanin in our skin need to think about. So not using sun lamps or tanning booths or anything like that, and making sure that we use sunscreen whenever we're outside. And then the seventh behavior is to protect yourself from sexually transmitted infections. So the one that I think most people know about is HPV. HPV is a sexually transmitted virus. The good news is that we now have an HPV vaccine where youth around the age 9 to 11 can take the HPV vaccine to reduce their risk of being exposed to the virus. That virus can contribute to the development of cervical cancer. But there are other cancers that can be associated with repeated exposure to sexually transmitted infections. The repeated exposure to sexually transmitted infections could also increase your inflammation, which could also increase your risk of cancers. And so the eighth tip for cancer prevention is screening, right? And we've heard a lot about screening, particularly for breast and prostate cancer today. And that's the eighth tip. If you can't prevent the cancer, the next best thing to do is to identify the cancer early. The sooner, the better. And the only way that we can do that is through screening. And so I'm going to do a quick rundown from colorectal cancer. The recommendation is for individuals. If you are at high risk now, from the American Cancer Society recommends starting that at 45 instead of 50. For prostate cancer, if you are high risk, again, talk to your doctor about your family history, about your PSA level. 40 for African American men who have a high risk based on their family history. If you don't have a high risk based on your family history, 45, and for all other men, starting at 50. Breast cancer, starting at 40, and Dr. Glover Collins talked about, unless you have a family history, and then you should start at least 10 years prior to the youngest person in your family who has been diagnosed. And cervical cancer, starting with pap smears as early as 18. In the state of Missouri, we have a program called Show Me Healthy Women. And in that program, it allows for a mammogram and a pap smear for women who are uninsured. They have to have an income at or below 200% of the federal poverty level and be at least 35 years of age or older. There's also Komen funding that a lot of hospitals have that provide assistance for women to have a mammogram. And again, my key takeaway here is always ask. Never assume that you don't have the resources or that the resources aren't available. So many of our hospitals and nonprofits in our area have resources available, and often they don't get spent by the end of the year. So always ask when you see a symptom, as Dr. Glover Collins mentioned, you should call your doctor and set something up. And if you need assistance, do ask for what you need, because there are resources there. So that's, thank you for having me.
Thank you, Dr. Drake, for providing that great information relating to prevention as well as resources that we can have. So we're going to ask our final two doctors to give us some final thoughts, couple of minutes, Dr. Hari and Dr. Catherine Glover Collins, for your final thoughts.
Thank you. So I just want to piggyback on what Dr. Drake had said. Like I said, I'm the Chief Medical Officer at KSGL Health, and our mission is to serve the underserved population. At KSGL Health, regardless of their ability to pay, we never turn away anybody. And we had recently even upgraded our mammogram to 3D mammography, so which has a better resolution than the 2D mammography. So we had done a complete radiological upgrade there. And one other thing I want to piggyback on what Dr. Drake said is the alcohol. And the American Heart Association says that it's okay to have one drink for a woman and 1 to 2 drinks for a man. And obviously the biggest issue often tends to be like, what is the size of the drink? And actually the American Heart Association does have, I think if I remember correctly, 1 drink is considered 185 ml or something like that. So it's not like, so people always get confused with what the size of the drink. And the other interesting thing Dr. Drake mentioned is vitamin D. So vitamin D is very essential. And I actually had a very low vitamin, actually as low as 7. And you know, my body is pigmented, and also I grew up in the tropical climate. So, but the best source of vitamin D is actually exposing to the sun. So it's so ironical that exposure to the sun also puts you at risk of actually having the skin cancer. But there are some endocrinologists who would swear and say that the tablets that we take are not the actually active ingredients because they need to be absorbed, and it is not the exact same thing like how your skin would make the vitamin D3 after the exposure. And also there are always this argument of like, what is the lower normal limit? They actually think that it is actually lowered because it's almost like you're dropping the lower level to decrease the incidence of actually having to look like people have vitamin D deficiency, because I have seen it being dropped. So definitely vitamin D3 in the right exposure. The time is, limit yourself with the UV index less than 8, and it should be minimum more than 3. Vitamin D is a huge passion of mine. That's why I'm sorry I'm digressing a little bit, because this is very relevant to the current pandemic we have. I don't know if people know, having a low vitamin D puts you at a higher risk of actually dying from COVID disease if you catch it too. So that's why do have the vitamin D, if possible, from skin exposure. The typical recommendation is 10 minutes on each side of your body. And Dr. Hood, I want to give you a big shout out, and you are a true hero. I'm telling you that you not only came forth with your personal experience, shared with a lot of the experience that they have. And one of the biggest thing I see in the prostate cancer after the surgery and treatment is a lot of the men, they're not comfortable even bring up these things. So when I train the medical students, I have med students who we train, we tell them that you have to create the conversation, the environment, and the comfort level to ask these questions. Not many men would be forthcoming and say they have difficulty with erectile dysfunction. They won't come forth and say that. And they won't even tell you that they're having any urinary problems. And then what we do is that we create an environment, what we call is the review of systems. And as we ask them many other things, the one thing we always focus on is that urinary retention, and of course, the sexual, especially the younger you are, the sexual dysfunction, because we do have to understand the World Health Organization actually defines what is a health. Health is a state of physical, mental, and social well-being. So if you just only focus on the body, you're going to miss the whole point, So quite often, this might lead to a chronic depressive state. And then if we don't properly, truly address it and do a multidisciplinary approach or treatment, we often will be left with adding on medication to every problem you have. Then you start trying medications with antidepressants, and then the antidepressant itself can cause some problems. So I think that, having the dialogue and having that conversation and creating that atmosphere of making them feel very comfortable, that actually makes a big, big, big difference. So just to cite one or two examples, I would even have no support staff with me when I'm having that one-on-one conversation. They feel more comfortable talking to a doctor directly. And I had patients referred to me in my practice where they were seeing a female doctor and they did not feel comfortable talking about it. So these are the things. So I just want to wrap it up that prostate cancer, when detected early, can be very, very, easily treated and almost can have near normal life expectancy. And please reach out for help, and there are always resources available. Thank you so much.
Absolutely, thank you.
Dr. Glover Collins.
All right, I'll be very brief. One thing that I want everybody to say is that cutting on cancer does not make it spread throughout your body. Stop propagating that and tell anybody who says that, stop saying that. That's the first thing. Second thing is what you don't know can hurt you. It can even kill you. Don't ignore symptoms. Don't be afraid. We're here for you. We want you to do well, and we only want what's best for you. So if you find symptoms, go and get it checked out. Go for your usual screenings, whatever that guideline you choose to follow, and we're here for you. That's it.
Thank you very much. And moving forward to the last segment here, we have introduced, first let me introduce Ms. Lanita Blackman, Vice President of Alpha Kappa Alpha Sorority Incorporated, Gamma Omega Chapter, and standing in for Brother Mark Cruz will be a brother that I'm highly respectful of. Brother Ira Hughes, who plays a very important role in social action within Phi Beta Sigma Fraternity Incorporated. And I was happy to say I was his dean. So if you all, and we'll always say ladies first, issue the challenge, and then we'll go to Brother Hughes. Thank you.
Good evening. Thank you to our panelists, Dr. Glover Collins, Dr. Drake, and Dr. Hari. We appreciate you taking the time to speak to our audience and bringing forth your expertise in regards to prostate and breast cancer. Thank you to our moderators and committee chairmen who assisted in making this event happen. And lastly, to our survivors, as hearing your personal stories always brings the reality of these diseases to the forefront. As we all know, cancer does not discriminate. As you know, October is known as Breast Cancer Awareness Month, and October 16th is known as Mammogram Awareness Day. Due to the pandemic, it has been documented that patients are hesitant to go to the doctor or health care facilities to receive their annual checkups. So the challenge to those of you who are watching this discussion is to make your appointment and be screened. Gamma Omega is partnering with the Seidman Cancer Center at Barnes Jewish Hospital and Washington University School of Medicine, offering mammograms on the mammogram van this Friday, October 2nd at the Jennings Station Road Urban League facility, and on Saturday, October 31st at Westside Missionary Baptist Church, located off Dunn Road in North County. If you are in need of an annual mammogram and would like to get on the schedule, please call 314-747-7222 or 1-800-600-3606. Once you make your appointment and arrive on site, take a photo and tag Gamma Omega, and we will provide 2 winners with a $25 gift card for taking the challenge. Early detection is always the best protection to fight any potential health issue. We hope that you are enlightened this evening and will be inspired to make your annual appointment if you have not done so this year. Thank you again for viewing our panel discussion this evening as Gamma Omega is celebrating 100 years of service in the St. Louis community. And on behalf of Gamma Omega's 391 members, we wish you a good evening and hope you stay and remain safe and healthy.
Thank you. Brother Ira Hughes.
Okay. Healthcare is a tough thing for many of us to face head on. However, as you've heard from Sisters Carter and Gaines, as well as our own brother, Dr. Mark Hewitt, it pays to be vigilant when it comes to your health. With that being said, I encourage you to be proactive by contacting your healthcare provider. Now is the time. If you don't have one, find one. I encourage you to assist and encourage other members of your family as well as friends, people that are in your circle. Again, I say, thanks for the participation, and I ask that you be on the lookout for future Sigma Wellness events. We want to thank each of you, and we want to continue to serve our communities. Thank you again.
Okay, as we wrap up this evening, first let me say thank you for Madam President of Alpha Kappa Alpha Sorority Incorporated, Kimberly Beck. Thank you to Brother President, Dr. Mark A. Hewitt of Phi Beta Sigma Fraternity Incorporated, my chapter president. And I want to congratulate the ladies of Alpha Kappa Alpha Sorority Incorporated on 100 years in Gamma Omega. That's an outstanding thing. We look forward to getting there soon in Kappa Sigma. It's been a wonderful event. I look forward to collaborating we do with you sometime in the near future again. We thank you for that. All the participants, doctors, those who have experienced and shared their experiences. It's been very informative. We can't thank you enough because people have been enlightened. And all I can say is what they've said before, don't be afraid to go to the doctor. You know, because fear is reverence and we don't give reverence to fear. And I'm not gonna start preaching, Doc. So I will say this, as we close out for this evening, thank you, be blessed, stay healthy, and do what you need to do. Have a good evening.
Mark, Robert, can I just take one point of privilege? We would be remiss if we did not congratulate Dr. Drake and Dr. Glover Collins on Zeta Phi Beta turning 100 this year. Also, we thank you, my sisters, for joining us tonight and sharing your expertise, but we would be remiss if we didn't acknowledge that this is your centennial celebration as well. So thank you for joining this panel with us and congratulations on celebrating 100 years.
Absolutely.
I should have recognized that. Yeah. And congratulations, my source. And remember, everybody, vote. If you don't do anything else, vote. Have a good evening.
All right. Have a good evening.